I'm Dr. Palumbo. I'm an investigator and specialist in myeloma who participated to these randomized studies and presented at plenary at ASCo the result of randomized control study comparing a new agent, Daratumumab, in combination with Bortezomib and dexamethasone versus Bortezomib and dexamethasone in relapsed refractory multiple myeloma patients. Why this new agent is so important? Daratumumab is a monoclonal, a human monoclonal that is directly against one of the most relevant tumor antigen for myeloma plasma cell, CD38. This increases significantly the capability of the monoclonal to attach the tumor cells and increase the tumor reduction throughout complement and antibody-dependent cytotoxicity, but is also able to increase the immunostimulatory effect of the immune system that is quite relevant to controlling the tumor in the long run. This is the study's design. As you can see, the key eligibility criteria were relapsed refractory multiple myeloma with at least one prior line of therapy. Prior Bortezomib exposure was allowed. The combination was Daratumumab at 16 mg per kg every week for the first 3 cycles, every 3 weeks from cycle 4 to 8, and every 4 weeks from cycle 9 until progression. Both Bortezomib and dexamethasone were used at the standard dose of 1.3 mg twice weekly and dexamethasone at the dose of 40 mg twice weekly. These are the baseline demographic and clinical characteristics. This is what you usually find in this type of studies. Median age was 64. Time from diagnosis was 4 years. Almost 70% of patients in both arms were already treated with autologous transplantation, proteasome inhibitor, and IMiDs. And 30% of patients in both arms were refractory to last line of therapy. So we are talking to a patient population already exposed to the majority of available agent in an advanced stage of disease. Here is probably the most relevant slide. You can see here the progression-free survival with an hazard ratio of 0.39 that translates in a 60% reduction in the risk of disease progression or death, and with a median for the control arm of 7 months and not reached for the experimental arm. But what is important to highlight that the 1-year progression-free survival moved from 26% to 60%. This means a doubling in the remission time for patients receiving Daratumumab. As subgroup analysis, all major subgroups benefit from this novel combination. The benefit was present independent from age, independent from prognosis of disease, independent from prior or later line of disease, independent from prior or not exposure to Bortezomib, IMiD, or even refractoriness to this compound. Another important finding was that the response rate was basically double for both for complete response as well as for very good partial response. There was a clear doubling in the proportion of patients who achieved this profound cytoreduction. But what was even more relevant is that MRD negativity was 5 times higher in patients receiving this free drug combination. Another important issue was that from a safety point of view, there was no cumulative toxicity. As you might expect, when you combine monoclonal antibodies with standard treatment, the monoclonals are not really adding a significant toxicity to the standard treatment already in use. Here, as you can see, the hematologic toxicity was limited. with around 10-15% of grade 4 thrombocytopenia. Even pneumonia was in the range of 8-10%, equally distributed between the two arms, and there was a slight increase of hypertension, but that was mainly due by the infusion rate at 200 milliliters per hour of the monoclonal. Both bleeding, infection, discontinuation for sensory peripheral neuropathy, and discontinuation for treatment emerging adverse event were equally distributed in both arms. The major add-in toxicity was infusion reaction. They were similar to what you see with many other monoclonal antibodies. 45% of patients experienced an infusion reaction, but the grade 3 was only 9%, and 98% of patients experienced this reaction only during the first infusion, and only 2 patients out of 250 had to discontinue the treatment due to infusion reaction. So the conclusion is that Daratumumab, in combination with Bortezomib and dexamethasone, significantly reduced the risk of progression of the amount of 61%. The benefit is present in all pre-specified subgroups, and Daratumumab doubled both VGPR rate and CR rate, but also Daratumumab was not associated with any cumulative toxicity.